Hey there, everyone. Thank you so much for joining us for today's webinar, which will focus on medical device reimbursement and upcoming rule changes that are set to take effect in 2021. I'm Rohit Seth. I'm the Director of Marketing here at Adaptiiv, and I have the distinct pleasure of being joined today by Jordan Johnson, the Director of Data Science at Legion Healthcare Partners. Jordan, why don't you tell us a little bit about yourself and a little background?
Sure. Jordan Johnson. I am the Director of Data Science at Legion Healthcare Partners. Um, Before that, I've been a clinician in radiation oncology as a radiation therapist. I've been a patient advocate, treated both of my parents, really have seen kind of all aspects, been part of the billing and coding and financial aspect of our profession. And so have seen all aspects and new technologies come about. So I'm looking forward to this webinar.
Yeah, we're really excited to have you and talk about reimbursement and CPT codes and whatnot. It's something we haven't really offered to our customer base and folks out there. So really excited to get started here. For those that have attended some of our past webinars, you probably know a lot about us. I'll go through briefly just what Adaptiiv does and what we offer to the radiotherapy market. We're a fully regulatory cleared software solution that you're able to create and design patient-specific RT accessories for use. So that would be bolus or brachytherapy applicators that are custom designed based on the patient's CT scan. We're very proud to be recognized as the first 3D printing software solution for use in RT to have FDA clearance. And we'll see the next slide when we received that in 2018. We offer 3 different software modules right now. We are working on numerous more that we're set to release in the coming year and next year. But we have 2 in external beam radiation therapy, so EBRT. That'd be simple bolus and modulated electron bolus. As well, in brachytherapy, we have high dose rate surface brachytherapy, and coming soon in the next few months, we're going to set to be releasing intracavitary and interstitial brachytherapy applications. So very excited about that. Earlier this year, we released version 3.0 of our software, which included a brand new feature called 3D printed molds. And I'll show you a little example of that in a few slides, where it's really cool, where you can make skin safe silicone bolus that's very pliable and molds right to the patient anatomy, as you'll see. We also, in version 3.0, added many new enhancements to our brachytherapy module, our HDR surface brachy module. Where, for example, you can even visualize the PTV now in our software as you're designing the applicator with the, body structure and whatnot and underlying tissues and organs that you can see and protect from as you're designing the applicator. So very cool stuff. Love to show you at any point, all of you, a demo of our software where we can get really into it. And yeah, as I mentioned, stay tuned for that new module with the ICIS and another version of our software that we're also working on right now that's set to be released later this year as well. Here's just some examples of 3D printed bolus in use. So as I mentioned, surface brachy, HDR surface brachy is one of our software modules. And as you can see there on the left, at the top is a scalp, actually. And on the right is a nose brachytherapy applicator. You can see a kind of face-on view on the top there. And here is where, you have our software. It comes into real benefit here. We have, first of all, numbering of each catheter tunnel there, which allows you to kind of label your catheters, and you'll know which one to put them in when it comes time for treatment. These hollow catheter trajectories are created within our software. They have a constant user-defined standoff and separation distance. As you can see, the even separation there with our scalp and nose applicator it's superior, compared to manual techniques that take a lot of time as well and don't, ensure that you have constant standoff distance separation between the catheter tunnels. Talked about 3D printed mold. So here is a 2-piece shell mold. We also have a 2-piece block mold that we'll actually see a little video clip of in our next slide. And basically what is produced, and this is a patient-specific breast bolus that is silicone. It's skin-safe silicone. It's been validated and cleared through our regulatory process as well. Simple bolus or uniform thickness bolus. This is a chest wall here. So this is another example. Again, very a patient-specific fit. Our MEB module, improves sparing of healthy underlying tissues, as well as significantly reduces or even eliminates hotspots in electron treatments, so which is really great. This is another type of product that exists that can be used with 3D printing. So, patient-specific mold for electron apertures. And we're actually, one of the things we're working on is apertures within our software as well. So we hope to have something for use in, the near future. So stay tuned for that. Here's that video I was talking to you about. So this would be a 2-piece block that is patient-specific, designed in our software. It's filled with skin-safe silicone. And then this is the end product. So as you see there, it's very soft. The video does not do it justice. It's soft to the touch. It's very pliable and fits on patients without almost the need for any tape. So really nice feature there.
Hey, Rod, I just want to take a minute. We have one of the questions come in. I think that's relevant to the timing here. But how long does it take, the production process? How long does that take? And then how long does a patient have to wait for treatment?
In terms of the silicone bolus or just any?
I guess we go over both of them. I mean, just producing either the silicone bolus or the actual, the more rigid bolus, either one. We can do the soft, pliable, and the rigid.
Yeah, we have a lot. So it depends on the size of what you're printing and designing. Really, the design in our software can take a matter of minutes. It's really simple point and click automated functions. We have very intuitive step-by-step procedures that can take you through the whole process. And then basically you export it back for verification in the TPS. And if you're happy with it and it doesn't need any more modifications, you can just export the STL file for print. So, we've had some cases that have been done in 2 minutes, usually between half an hour to an hour in our software, not an onerous process at all. And then the printing, it depends on the size of the bolus. So say a large chest wall, I think that takes anywhere from 12 to 14 hours to print. So we have a lot of clients that will print overnight, or when they're not not treating patients or when the printer has some downtime. So we see a lot that do it overnight, and then you come in the next morning and the bolus is ready for treatment. You don't have to wait with the patient there. The patient comes in, you put it on, with the chest wall or something like that, a couple pieces of tape, and you're ready to go. Even the brachytherapy nose applicator I showed there, that takes a few hours to print. So, it can be done during the day or again, overnight, ready for the next morning's treatment. The silicone bolus is a little longer. So you print the mold, and then the silicone pouring process is a little more onerous, probably takes 3 or 4 hours to kind of complete that from start to finish. It's more arts and craft, but the end product is uncomparable to anything we've seen. So that's roughly, hopefully that answered the question.
Perfect. Absolutely.
Anyone through our workflow in detail at a later time. Thanks for that. Just some partners and customers and partners of ours in the US that we work with. Recently, we just signed the Mayo Clinic, actually very proud to have them on board, in addition to Banner MD Anderson and Scripps and Cedars-Sinai. They're our most recent signing. We've had longstanding relationships with Indiana University, University of Chicago, Kaiser Permanente, Walter Reed has been a client of ours, as well as you can see the others. So very pleased, very happy with our customer base. These are major names and in the US and the worldwide radiation therapy and radiation oncology market. So we couldn't be happier. We're pleased as punch to have these folks on board. In terms of collaboration, I'll just make one point here. We encourage every customer to provide insight and feedback about our software, even before they become a customer. We've had some, and their feedback actually helps influence our product roadmap. So we have the fortunate, ability of having a dedicated team of software engineers and developers, as well as medical physicists that can take customer ideas, prototype them, and quickly turn them into reality. We've actually done this for several customers already, Banner MD Anderson being one, which they had some feedback on our brachytherapy module and for improvement. And we implemented that and within a short period of time. And now it's part of our brachytherapy offering. So we love to hear the ideas from our customers and work with them to apply them in a clinical setting. So it's not just our software; it's theirs and yours as well as a customer. Here's a typical customer of ours, and this would be probably a small to medium-sized customer. There's some larger organizations that would probably achieve payback in a shorter period of time, but this is a typical, customer that probably prints between 120 and 150 bolus or brachytherapy applicators a year for individual patients. And so you can see here, the average cost to 3D print is about $160 per patient, and that's an all-in, including the filament, printer, cost, spread out over time. Our upfront cost, obviously, of our software, as well as the cost to print with the filament. So, you can see the average cost for each 3D print is about $160, and then your CPT reimbursement, which Jordan again will go into, is quite significant per patient. It may vary across different states, but you can see here after about 5 months of using our software, this customer actually achieved payback after about 23 patients. So a very short. So hospitals can overcome that upfront cost pretty quickly and start, profiting from using our solution. So basically turning your organization from a cost center to a profit center. In ARIA, care paths can be created for a variety of different things, clinical, operational, or financial workflows. It basically ensures the tasks are being completed, and they automate and auto-escalate overdue tasks for completion to the users within the hospital. So with ARIA and our integration, users are actually able to increase the use of 3D printed bolus and using it. And it also reminds them to bill for CPT codes. So, that results in improved processes, allowing centers to meet their goals in providing high quality patient care, which we all strive to do. So, again, love to take you through more of that in further detail. And now I'll hand it off to Jordan, where he'll take us through some billing and reimbursement guidance.
No, absolutely. Absolute pleasure. It's been a pleasure to follow Adaptiiv. It's great to see disruptive, innovative technology all too often, especially, as a clinician, I've mixed many a bolus of dental alginate and made a mess. And then you got to keep it in oil and you got to keep it disinfected. I've used wet towels and experienced and had my staff, crash the MLC motors when it's at a lateral position because water gets in the head of the machine. So I've had all that and I've followed, and it's good to see something absolutely that's innovative and disruptive. We see certain things, maybe it's a mask and now it's a 2-piece mask, but listen, it's still a mask. That's really not innovative. And we have a lot of that stuff. So it's been great to see this technology that adds value, but also has a clinical component that is beneficial. So before we get into the coding, I guess one question I have is and it's a question that just came in, is does each center have its own printer, or is there a by mail option to send plans to a main printer and then ship it back? That's a question that came in, and then I'll jump into this.
Yeah, so that's a great question. Currently, we offer the in-house solution where you can purchase the printer through us and do the printing on site. Some centers have 3D printing networks, so they already have 3D printers. And like I said, any printer can be used with our software. So they almost have like a hub and spoke model where they'll have a central location that prints the accessories and then we'll send them out. We're currently working on a model where we would actually provide that service as well. So it's still in the works. Nothing's set in stone yet, but our hope is that we'd be able to offer, where a customer would basically do the design in our software, ensure it's validated in the TPS, and send us the STL file where we'll print and ship either bolus or applicator to them.
Got it. That's awesome. So I'll jump into some of the reimbursement. I mean, the biggest thing is our CPT codes. And the first code that obviously this covers and would be applicable is the device itself. And that's CPT code 77334, which is a complex device. It's interesting. In the device world, so many people, it's like, well, it's kind of customizable. It's not customizable. Can I bill for it? Can I not bill for it? And there are so many things out there that simply just aren't billable, or it's not billable in multiple quantity. I mentioned earlier, it was a big thing. I've got a mask and now I have an anterior and a posterior mask. So can I bill the device complex times 2? And obviously the answer is no. But this takes away the guesswork. Nothing gets more customizable than making some type of bolus from the patient's actual CT scan. So some of the other codes that possibly may be necessary. Obviously, the 77331 special dosimetry, this could be something. Obviously, we would need a report generated by the dosimetrist or the physicist, and then the physician's going to sign off on that. But if we're looking at specific dose measurements for that bolus, this may be needed. Obviously, the 331 is included per Chapter 4 of the Medicare Claims Processing Manual with IMRT, so we would not bill that with the 77301 IMRT. Same thing for the 370 and 290, but the 370 special physics consult, again, we're going to have it ordered by the physician, and then a report's going to be produced saying what was needed, how did the plan adjust, what did he need to do with it, with that bolus, and then the physician's going to sign off on that. So there could be an instance where that could be needed. And then obviously the 77290, 280, whether we're talking about, the SIM verification or the complex SIM, if it's developed from scratch and things are drawn on in the room, and we start setting that up in the room, we have a 290 situation. The 280 situation would be at the machine when the patient's getting ready to use the device for the first time. The physician has to come to the machine. It's more than just checking the image. He's already going to be able to check the image with the bolus applied and see that, but then he's going to see it on the skin. And that's where another 77280 for the verification could be billed. So again, these are the codes that would be associated with us and this adaptive technology.
Yeah, and that's where I referenced the $1,800 CPT code average reimbursement per patient in the customer example there. It would include more than just 77334. Thanks, Jordan.
No problem. So, we get into the rules, and I think some people have heard me talk about this before, but is it complex and customizable? And that's the first thing I ask, and immediately everybody is like, well, it's complex. It could be customizable. We can adjust these settings. And I'm like, there's only 4 settings. So then it's not customizable. And then we get into, is it reusable? This literally checks all the check boxes. It's complex. It's customizable. If you're printing from the CT data set of a particular patient, it can only be used for that patient. And not only for that patient, but for that disease site that they're actually treating. So it's a no-brainer. That this would be a billable device. Still needs to be ordered, still needs to be documented. And we know our medically unlikely edit is 10 for 77334. I always put that on there because, you may have other devices. Generally, where we would see this, you could have multiple complex devices. So this could be built in addition to a mask or a vac lock. So this is something you should have in your compliance plan. If you're using this product, it definitely needs to be in there. Or what are the utilization parameters, how you're going to use it, when you're going to use it, and then the billing procedures. What's the code? Obviously, 77334. When do you bill it? Who has to sign? There needs to be an order and documentation. That's all going to be in the compliance plan, but that's just something I'd like to point out. And then the physician's going to review. I touched on this in the previous slide, but at the SIM verification, when they come, they physically have to be there. So if this is ordered, it's documented, it's been created, he's signed off on it, he's probably looked at the images in the treatment planning system, they're still going to require physical presence at the machine for that first day that it's going to be used. Again, to make sure, is it within the margins and the parameters that the physician intended, light field, SSDs, that bolus placement from within. Again, all that has to happen at the machine. And when those criteria are met, that's when we would see the 77280 for SIM verification, pending that it's not IMRT. So just last week, the proposed rules for 2021 were released. So what are we looking at? What are the changes? And just an overall, the OPPS, which is our hospital setting, saw a 2.6% increase overall. Our NPFS freestanding for radiation oncology in particular, saw about a negative 6% decrease. The biggest decrease for the freestanding was the conversion factor. The conversion factor went from about 36.0892 down to about 32 and some change, which is about a 10% decrease. So we saw some pretty significant decrease. Again, not set in stone right now. as these were just the proposed changes. We have 60 days. Lots of comments will be sent to CMS, especially for those freestanding, some of those cuts and balances. But just wanted to talk about the codes that we've talked about. What do those changes look like? For your hospital environment, for the next few slides, hospital is going to be on top, freestanding on bottom. But for the hospital, code 77334, which is our complex device, in 2020, where we are currently, we're about $335.12 at a national rate. Obviously, this varies based on geographic location. But for 2021, we're going to see it go to 346.33. That's an $11.21 increase. So that's pretty significant on the hospital side. For the freestanding, I mentioned we saw about a negative 6% decrease for radiation oncology, the decrease in the conversion factor. So with those two things noted, we would expect to see a decrease in these codes, and indeed we do. In 2020, we're about $130.28 at a national rate, going down to about $119.36. That's a $10.92 increase. And just interesting that, in one, they're almost identical. One's an increase, one's a decrease from hospital to freestanding. So with that, I guess we'll go to our next code.
Actually, Jordan, a question just came in, which probably be best to address right now.
Oh, sure.
So is it best to receive prior authorization for payment before developing these devices so you don't get stuck with a bolus that won't be covered, for whatever reason?
Absolutely. And it's not going to be a prior authorization that's unique just to this bolus. I can't stress this enough. We deal with a lot of clients, but prior authorization is the key now. It always has been, but even more so now, because we want to get things approved on the front side. So when a patient comes in for treatment, they have that consult and that doctor's decided, all right, I'm going to treat this patient. This is how I'm going to treat them. It's at that point that we go. If it's traditional Medicare only, we don't need a prior authorization. But if it's a Medicare Advantage plan, a commercial plan, then we've got to be able to get that prior authorized from beginning to end. So we submit all the codes and their quantities. So that's exactly to the point where we would like to have this 334. If this is something we're going to use, then we would know that the devices, this is the total number of devices we're going to see. So we would put that in the prior authorization and hopefully get that prior authorized, before the patient comes in, and we get that taken care of. But absolutely, the key is fix it on the front side, because if you don't and you get to the back end, there is no retro authorization. All of a sudden, we forgot to do it or we didn't get the quantities right. Maybe they'll pay us. The answer is no, they won't pay you. You do this on the front end and you get this correct. So absolutely, that's a great question. Prior authorization on the front side for sure.
Great. Yeah, and anyone who has any questions, please feel free to type them in the chat throughout the presentation. We'll address them if we have time at the end. All right. And here we are.
So the next code, again, hospital on top, freestanding on bottom, would be that the special physics consult, the 77370. Not surprising here. I mentioned that the hospital saw a 2.6% increase. So right now we're about 126.58 as a national rate, and we'll be headed to 129.86 if the proposed rules stick. That's a $3.28 increase. Now for the freestanding, again, in red, fairly close to what the increase was for the hospital. We see is the decrease for the freestanding, but going from 126.67 to 123.24. So that's a $3.44 decrease on the freestanding physician side. Next code, and we'll go, is that the special dosimetry, the special measurement that we would take for looking at dose. Again, same increase. It's in the same APC category on the freestanding, so it's the exact same increase as the previous code, the 370. It's a $3.28 increase from 20 to 21. On the freestanding physician side, we're going from $66.40 to $60.33. It's a $6.08 decrease. So with that said, let's go to the next one. I think we get into some of the where things are going. This is really where the technology shines to me, is where we're going moving forward. Y'all have heard me talk for years, and now everybody is more interested than ever, it seems like. But in data, as we move to a value-based care model, and really what does that mean? As we move to these alternative payment models, there's a big push right now for outcomes transparency and price transparency. And I mention outcomes transparency here because, skin reactions matter. If they're bad enough, the patient may have to have wound care, hyperbaric chamber services or wound center services, that is a halo cost to the outcome. So it's important where we could eliminate some of these skin issues by having something that's unique and specific to that patient based off their data set. Price transparency is another big one. We know that coming in 2021 in January, all the price rates are going to have to be published by all the hospitals for all their commercial payers. We have Medicare rates, the charge masters are already posted, but this is really going to open the waters and hopefully level the playing field where people are going to see, okay, how much does this cost? And then we're going to get into, value is going to be the expectation, and compensation models are 100% going to be based on this. Two-sided risk, very similar to what I mentioned before, is that a patient has treatment, things are done, and that we don't want to see them return for other care because of how they were treated or a readmission or something like that. And that's that two-sided risk. We're going to be paying for performance. So that's where outcomes are going to be measured, value is going to be measured. And what this is ultimately going to do in radiation oncology is really transform our operational process. What truly adds value. So the things that we use currently are going to be assessed. And is it needed? Is it not needed? What decreases the variability and promotes standardization by far is going to be one of the biggest drivers, not only for an individual center, but also for a larger network. It'll become more significant for a larger network, which is, again, where I see something like Adaptiiv. If I've got a printer that prints, everything's consistent, whether it's in multiple locations or a centralized location, that we can decrease variables. We know we're not going to have some air gaps on some patients, some on not, but decrease the variability, which will drive hopefully a better outcome. And then overall, that's going to promote a standardization across the system or across the department. And then the name of the game is going to be, what's the cost per outcome per patient? It's costing models, not how much you bill, but how much did it cost? And again, the one thing that people often forget to figure in is, resources consumed to take care of the patient, halo cost around if something, if there's a uncontrolled skin reaction, they have to seek other services. All that stuff is going to come into play based on their diagnosis. So that's kind of where we're going as a whole for value-based care. And essentially what the radiation oncology alternative payment model will be is one lump sum base based on the diagnosis. And this is where, to be, I guess, straightforward, is kind of what separates the haves from the have-nots. So people are going to assess, what have we been doing, and have we been doing it simply because we could bill for it, or does it really add value? And that checklist is going to come across. And I think this is where not reinventing like many people have versus being disruptive and innovative, which is the pathway that Adaptiiv has been on, I think is going to separate. You'll see two separate distinct lines. So that would be my overview of value-based care and where we're going.
That's amazing. Thank you so much, Jordan. That was a great overview. And thanks for updating us on the proposed rule changes there. So that concludes our presentation and webinar for today. We do have some more questions coming in, so I think we have time for one more. And again, if we don't get to all the questions, we'll follow up with you after this, and we'll send a recording of the webinar out. One question for you, Jordan, that has come in is, which treatment sites have been shown to be more positively impacted by truly custom devices? It seems like there's lots of head and neck applications, but are there other sites too? And I can try to help there, but I would defer to your expertise.
Yeah, and I like it because it comes back to my clinical side. Is definitely breast air gaps were always an issue, especially on the, as we treat the medial lateral tangent, where we're using wet towels, we're using superflab. And if you were using superflab, it was, lots of tucking and taping going on. And then you're trying to protect their skin that's already sensitive. That's one area. Another great area, and because I've done a ton of them, was like ears and noses. The best way to do those currently is you're either using like Vaseline gauze, or you're using dental alginate is still probably one of the biggest ones that we did, where you're mixing that same thing they take your teeth impressions with. That's a little bit pliable, and it is an absolute mess to create that stuff. And so that's really where I see some big benefits. Now, other benefits are obviously the brachytherapy. Brachytherapy, as we move forward, I think we're going to see an increase in the utilization of brachytherapy. And that's where some of these devices that are being created now for the IC and the IS models, as you mentioned, that'll be coming out, that are going to serve as very, very important. I think a lot of people don't understand the physics behind brachytherapy, but it really is all about how accurate down to the millimeter the channels are for the catheters to pass through and things like that.
Yeah, and we actually have a patient case with ear using our silicone bolus. So using that soft, pliable bolus, so you reduce or remove and eliminate that Vaseline type of application and uncomfortable and unpleasant for the patient type of approach. So yeah, stay tuned for that, everyone. We'll be sending that out, via email or on our social networks in the very near future. Looks like we have one more. Actually, we're in the essence of time. We'll be respectful of everyone's time, and we'll address some questions in the follow-up as we send the webinar recording out. So really, I'd love to thank you, Jordan, for providing your guidance and expertise when it comes to billing and reimbursement, as well as the rule changes. We hope that we address, all aspects here of the technical, practical, and reimbursement models that can be applied in the RT industry. So again, thank you so much, Jordan. Really appreciate your time. And to everyone else, please be safe and stay healthy and enjoy the rest of your day and time here. We'll look forward to speaking with you and seeing you again in the near future.
Absolute pleasure. Thanks so much.
Thank you.